pull it. No, I can get to it. Yeah, I'm get to it.
Pastor Stevenson, can you hear me? I'm testing my audio.
Yes, I can hear you loud and clear.
Thank you. I was getting an error message and I just wanted to make sure it was coming through.
Oh, you're coming through just fine. I just sent you an email, but actually I found it. I found the link, so we're good.
Okay.
So ignore that email.
Oh, okay, perfect. You have the packet and everything you need though?
Yeah, I have everything I need. Yes.
Okay, great.
Hello.
Hang on a second. All right. Can you hear me okay?
I can. So we have Ms. Fisher. Is Mr. S, is Pastor Ed Sanders on? Pastor Ed, was that a yes or a no? Okay, we'll go with Ms. Fisher. That gives us a quorum. Welcome. I'd like to call our Finance Committee meeting to order. And I move that the items on the meeting agenda constitute an essential business of this committee. A meeting electronically is necessary to protect the health and safety and welfare of Tennesseans, considering the COVID-19 outbreak and any rule that conflict with the governor's executive order permitting electronic meeting be suspended. Can I get a second?
You got a second.
All in favor, vote by the sign of aye. Aye.
Aye.
Ayes have it, and so we are now approved to meet electronically. And so our first order of business on the agenda is the conflict of interest by Derek Smith. Are you available? All right.
I am available, Committee Chair Stevenson. This is simply a placeholder on the agenda for an opportunity for any committee member that believes that they have a potential conflict of interest to make a disclosure and then make a decision as to whether they believe they can remain unbiased and objective and therefore conduct the business on the matter for which they might have a potential conflict, or that they believe that they should recuse themselves. I, as the attorney for the committee and the hospital authority board during its meetings as well, am available to be consulted with. And I would suggest, if it comes up in a meeting, I'm available to be consulted with, but also it's a better and a good practice to take a look at the advance packets. And if you see something for which there may be a potential conflict of interest, reach out ahead of the meeting, and we're able to offer some legal advice if you have any such desires. So that's all I have, unless there's further questions.
Thank you, Attorney Smith, for that information. We'll move forward now with our approval of our minutes. And I move that we approve the February minutes. Can I get a second?
Second.
All in favor, vote by the sign of aye. Aye.
Aye.
Any nays? Ayes have it. The minutes are adopted. Next, we will have our COVID and ACS update. Bruce, if you're available, we'll hear from you about that.
Yes, thank you, Frank. Just two things. The first is that I think we mentioned it at the last meeting, just to reconfirm that the alternate care site, which is operated by TEMA, the state, and they rent space from the hospital, that they have indicated that they will close that site and terminate the lease. It runs out May 31. So that process has already started. It's in the planning phase. They will remove their supplies, their beds, some of the limited equipment that's on 2 and 8, and they will return those spaces to the hospital. The second floor doesn't require a significant amount of work to put it back into the condition it was before. The 8th floor is where they did the majority of the construction. And ideally, if FEMA could, we would like for them to leave the improvements that they put in place, but there are some federal requirements. They may have to return it into the same condition, basically, that they received it, which is unfortunate because they had created walls and spaces in there and sinks that we would prefer that they leave them in place. We're having those conversations, but it looks like from TEMA's standpoint and under FEMA that they may have to deconstruct, spend money to basically tear out what is in their improvements on the 8th floor. So that's going to end May 31st, and that $70,000 a month rent income that we receive for that space will end May 31st. So that's just a heads up on the alternate care site. The second one is just an update on where we are with our $10.2 million. I think Sharon's putting it up for you so you can sort of see. The three tranches that we received those dollars, the 375, then the 459,000, and then the big one obviously was the safety net dollars that we received, 9.4, total of 10.275 million for COVID relief. In fiscal year 2020, we drew down $2.6 million for lost revenue impacts, which is allowable under the CARES Act. And then we had expenses that were offset about 473,000. And those were all counted and reviewed as part of our audit that was closed a few months back. So at least those are audited numbers. In addition, thus far through the first 8 months of fiscal year 2021, we have about $3.2 million of revenue, net revenue impacts that we were able to draw down dollars for, and then about $2.1 million for expenses. The majority of those are wage and salary expenses for the COVID differentials or retention payments that we made for staff that were in high impact areas where they were taking care regularly and persistently COVID positive and COVID rule out patients. It was primarily our ER, our ICUs, the 6th floor where most of those patients were housed, and then respiratory therapists and others that took care of those patients regularly. So that's the majority of the spend there. Unfortunately, the CARES Act does not allow us to pay the salaries of those people, only any additional unusual expenses related to those costs for caring for those COVID patients. So you can see after those items through the month of February, we have about $1.9 million remaining of CARES Act funds. Those funds, as it currently stands, must be absorbed, expended by June 30th of 2021, or the potential could be that any unexpended monies would be returned to CMS at that time. We have been having impacts that are somewhere between $400,000 and $500,000 a month. So if it continues, we probably would spend all of the money before the year is out. But I will say the COVID impacts at the hospital have subsided, thankfully, in the last, say, 30 days. And we'll have to see how that goes. But that's not our money to just use. It can only be used according to the CARES Act for COVID relief or COVID preparedness in the future. But the monies do have to be expended by June 30th of this year. So that's the CARES Act update, Mr. Chairman.
Thank you. Thank you so much. Are there any questions regarding that? If
I don't
not,
have any at this time.
okay, so we'll go to the next agenda item, which is an update here for the critical capital needs.
Right. And Mr. Chairman, I'm very pleased to report that on March 16th, with support from Dr. Fagans and really the entire board, certainly this finance committee, Metro Council, with the support of the mayor's office, they did approve $1.06 million of 4% capital money. The biggest items on that list were a second refurbished CT unit, so that we won't just be one deep in CT for diagnostic going forward, and we won't have to go on diversion when the one is down with a maintenance issue. That's a little over $500,000. The second item on that list is a refurbished angiography suite capability that would allow us to run our cath lab and an angio suite at the same time, because we have two full-time providers in those areas. And right now they're sort of fighting for times in our cath lab. So this will give us the ability to do small cases in the angio space and the bigger spaces in our cath lab, and predictably get those things done the day of need rather than having to put them off for another day which will reduce staff costs and improve the care delivery that we're trying to provide here at the hospital. The third item on that list is a fracture table. We have 2 full-time orthopods working at the hospital, and a full-time podiatrist, and also a PA that works in that space as well. We don't have really a fracture table that is stable with the hydraulics in place to allow our orthos to do some of the bigger cases that require really mobile, really static holding patients in place, or when they're doing a significant ortho procedure. And it's something that we've been needing for a while, and we're that's be a little less than $100,000, and we're trying to get that fracture table in the next couple of weeks for our ortho docs to try it out and see how it works. Alternatively, we may have to visit another hospital and bring them with us just to get their concurrence with it. It's a big need for the hospital, and it'll be a convertible OR fracture table where it could be used for regular general surgery purposes on those days when it's not being used for orthopedic care. So those are the big items. We're very thankful, very desperately needed capital, and 3 really high priority items for the hospital. So that's I'm really pleased to report that that's been approved. And so we're moving forward with those, Mr. Chairman.
Thank you. Thank you for your leadership to really lift up some really important capital needs and to ring the bell loud enough to get the attention. So that's fantastic news.
It is. Thank you.
All right, we'll move right along to our critical, to our 2022 budget.
And Mr. Chairman, this is just information. We, at the last Finance Committee meeting and board, the board approved this preliminary budget for the hospital. It will be submitted. It was preliminarily submitted to Metro a couple of weeks ago, but we will make our budget presentation to Metro on the 31st, a week from yesterday. So at this time, this is the budget that we'll be going forward with. It is a request for $49.56 million in terms of subsidy. It hasn't changed from what we looked at last month. We'll have to see how that goes in the budgeting process. And for any changes that we need to make to the budget, we will bring those back to the Finance Committee and the board for final approval before we enter the new fiscal year, July 1st, 2021.
All right, we'll move right on to financial statements.
All right.
January and February, and we'll approve those respectively.
All right. And Mr. Chairman, just a reminder, last month when we did our December financials, Christine Crowley actually presented our January revenue cycle. So we're going to skip January revenue cycle here. It's already been presented, although it's in the packet if anybody has any questions. And when we get to February, I'll let Christine step up and give the February report. And if there are any questions about February or January, she could address those at that time, if that works. Okay. So for the month of January, our volumes dropped off a little bit, about 10% from the prior month and well below budget. Our observation visits were up slightly from the prior month, but still below budget. And most of that below budget on both admissions and certainly OBS visits is our ER volume. That's been down about 30% since COVID started, and they're still staying down at that very low level. I just think people are staying home unless it's a really significant event that needs emergency care. So that's hurting our numbers a little bit on the inpatient side and the outpatient side of the house. Patient days were actually up, down a little bit from the prior month, but well above budget. Unfortunately, that was more about length of stay because the admissions were below budget, but our length of stay was well above budget, about 28% higher at 5.7 days. Our ER visits, you can see, were 28% below budget, just below 2,000. And our emergency admissions, about 15% below the budget. Our clinic visits were well above budget, about 17% higher than budget for the month, positives. But surgery just generally was flat to down slightly compared to the prior month and behind budget. Cath lab is busy. And as we said, that angiography capability, when it's brought online, will allow us to even increase those volumes further. In deliveries, newborns down slightly from the prior month and slightly behind budget. But the thing I would point out, because it's going to be material in a minute, is our case mix, our hospital inpatient case mix is pretty high, 1.75. That really is a measure of the acuity of the patients we're taking care of. That's significantly higher than our budget year to date. Last month was high as well. A lot of that reflects the acuity of our COVID patients in the inpatient setting. And that's really a reflection of not just their revenue intensity, but the resources that they absorb when they're in the hospital. So that's a good thing to have higher case mix, but it does drive some costs in the hospital. So next page, Sharon, please. So these are the financials, the income statement for the month. You can see that inpatient revenues, even though the admissions were below budget, inpatient revenues were 21% above budget. And that's because of the intensity of the care being delivered for patients on the inpatient setting. On the outpatient side, because our ER volumes and our observation volumes are down with COVID, we fell about 13% below budget on the outpatient gross revenues. So total revenues were about 3% below budget for the month in total. When you look at net patient revenue, so what did we harvest from that $21 million? We were well above budget, $4.2 million of net revenue. Budget was 3.9. And the reason we run a 12-month rolling history here at the hospital of our collections to estimate net revenue. And we have had 3 or 4 really great cash collection months, really starting in November and through February. Probably we're averaging a little over $5.5 million. And you'll see those in a minute. But as those numbers keep coming in, it tells me that my reserves are too high. So that's why you see this net percentage at almost 20% versus a budget of 17.6. That's good news for the hospital. So all in, we also had a significant benefit on the essential access of about $380,000. That is federal and state money that comes in. We don't control it. I do think there's been a bump all year from COVID at the national level. So all hospitals are seeing a little bit more money on the essential access side, and that we benefited from it all year. But it was about a $380,000 benefit. So for our total net revenues, $677,000 ahead of budget. Come back down to the expense side, you can see salaries significantly above budget, about $440,000, and our contract labor about $160,000 above budget. The primary cause, and I hate to say cause, we brought on a lot of providers on hospital salary and then the support staff to manage those clinics. And they were not budgeted last year. We weren't for sure certain that we were going to be able to recruit those providers successfully. But as I told you, we've got 2 orthopedic surgeons, an interventional cardiologist. We've got 2 urologists, 2 general surgeons that are in the employ of the hospital. And we do have to pay market wages to bring those physicians in. They're keeping these high-level revenues for the hospital, so they do benefit and they provide excellent patient care, which is really what we're here to do. So our expenses about $1.2 million higher than budget. The majority of that is in the salary and contract labor area. The others are some contract services that were unanticipated at the time. We've talked about it, that we were, I hate to say gifted, but we were handed the cost of the hospital security contract. It's about $80,000 a month. It was not budgeted. And so that's going to keep hitting for the rest of the year against budget. And then we also brought on radiology service and interventional radiology service. that is a six-figure contract between those two areas monthly. Those dollars used to be paid indirectly through the PSA, through the Meharry agreement. We brought those in to the hospital now, and I think the service levels are higher. Net, once we start collecting those professional fees, it should have negligible impact on the hospital, except improving the service and probably building volumes in the imaging space. So all in, our revenues were about 670,000 better than budget, but our expenses were 1.2 million behind. We did not make any accruals this month for CARES Act revenues or expenses of any substance. You'll see that in the February presentation. So for the month, we lost $600,000. Net income budget was a loss of 50,000. And year to date, that loss of 600,000 actually put us below the water line for the year to date, 570,000 negative margin compared to a budget loss of about 70,000. I would just note last year at this time, we were at a $2.9 million loss year to date. So there is some improvement. Certainly, we've been buttressed by the CARES Act dollars for the lost revenue impacts and a little bit for the offsetting of expenses. But that's our January report, Mr. Chairman.
Thank you.
Questions?
Just one quick question
Sure.
for me. On the security contract, who was paying that before?
It was the sheriff's office. There's a long history there, Pastor Stevenson. I don't know if Mark Overlock is on, he can probably give you better history, but for many, many years, the sheriff's office actually provided actual deputies to provide security here at the hospital. And then maybe 9 or 10 years ago, the sheriff's office, probably manpower issues, wanted to outsource that arrangement. And so we transferred money, or the city transferred budgetary line items from the hospital to the sheriff's office so that they could pay for the service that they used to provide out of their own budget. And so sometime last year, probably when we were presenting budget, we had heard the rumor that the sheriff's office was wanting to hand that benefit back to the hospital. And we thought, okay, well, if you just give us the $800,000 back in the budget, then all things would be equal. And unfortunately, in the budget process around with COVID and everything else going on back in February, March of last year, we were granted the expense, but we were never granted anything more than the 43-1 to cover that expense. So it wasn't budgeted. We didn't know about it at the time. We were fearful that it might come to pass. But I don't know if Mark is out there, if he can comment on the history there. That's what I know, Frank.
Reverend Stevenson, so this happened, I want to say 2009, roughly. We looked at outsourcing our security services for all three facilities, Bordeaux, Knowles, and General Hospital, and really went through about a 3-month process. And we're just about to pick one of the vendors, and at the last second, Sheriff Darren Hall came in and promised he could do it. And so basically $800,000 moved from our budget to his, and virtually all the guards that we had on all three facility campuses became sheriff's deputies at the sergeant level. So then, as Bruce said, over the years, that has sort of faded away, and now we're having to use a different service.
Thank you. Thank you so much for giving us some history and explaining it. That certainly will make an impact on your budget. Ms. Fisher, any questions or comments on January's financials?
I have a question on contract labor. Has that stayed pretty high for a need for nurses to treat COVID patients? How is our contract labor looking? I know we've talked about that over the years.
Yeah. Alex, it's gotten better. Obviously, it's gotten better recently because the travel nurse demands out there outside the state of Tennessee have dropped significantly because COVID is decreasing. And so not only are we seeing nurses return back to the state, in some cases to our employ, but we're also seeing the rates. We used to have ICU rates that were $66 and $73. They went up as high as $120 an hour. So it wasn't just the availability of nurses, which were limited, but it was the cost per hour went up, almost doubled over the course of a few months. But it was either that or closed beds in some cases. And I think Veronica Elders and Diana Wolfart and the team that have been working on ways to incent our nurses to work more hours, that's had a big impact the last, say, 6 weeks. And so it's starting to come down. If you look, last month it was 476. This month it's 400. And I think you're going to see a little less when you look at February. And just right now, I think that we are going to discontinue the COVID differentials effective March 31st for nursing in those areas, just because we really don't have any COVID patients in-house. And Veronica believes she's able to resource nursing effectively without having those differentials going forward. So those are all positives long-term. But yeah, contract labor is on its way down. We need to get it down further than $300,000 or $250,000 a month, and we're working on it, but it's got a ways to go for certain.
Thank you. I appreciate you bringing me up to speed on where we're at on that.
Thanks. Do you want to move on January on its own, Pastor
Yeah,
Stevenson?
Yeah, I think I will. So I'll do that
Okay.
now.
Okay.
I'll move to adopt the January financials. Can I get a second?
Second.
All in favor, vote by the sign of aye. Aye.
Aye.
Any opposed? And nay, ayes have it. And that's adopted. And we'll now move to the February financial statements.
Okay, so here's February. You can see a slight decline in admissions. Of course, it's a 28-day month. We went from 164 to 160. Observation visits, though, did drop pretty substantially. Patient days dipped back to sort of what close to budget. Our length of stay dropped from that 5.7 number to 4.9. So that helped keep patient days lower than what the prior month was. Emergency visits, and everybody remembers we had Snowmageddon in that, I guess it was the third week of February, whenever that was. So we basically had an ER volume in the teens for 4 or 5 days. And most of our clinics, our surgery schedule, most of the outpatient areas of the hospital other than the ER were effectively closed for 1 week. So most of our numbers were significantly affected by that. So I just couched that so everyone sees these numbers in context, that we basically lost 5 days of productive outpatient care, surgery, et cetera, in the hospital setting. So you can see our ER visits, which were 2,000 the prior month, dropped to just a little over 1,500. We still had a decent number of ER admissions at 131, but our clinic volume dropped off because the clinics obviously were closed for at least 4 days of that week. So the numbers dropped actually below budget for the first time probably in 2 or 3 years that we've not met the budgeted threshold for clinic visits. Surgery was down a little bit. Surgery outpatient was down a little bit, and even cath lab was down a little bit from the prior month. But really, if we had had that 1 more week, I think those would have all been at or above the budgeted levels. Deliveries, babies still come whether the weather wants it or not, but even those were down a little bit, but a little bit shorter month with 24 deliveries. Case mix was not as high as it was the prior month or the month prior to that, but still remains very high in the hospital at 1.67 as we're clearing out some of those last COVID patients from the facility. All right, you want to go to the income statement, Sharon? Okay, there you go. So again, as you heard last month, our inpatient admissions were close to budget. Our inpatient revenue was almost 20% above budget, and that was due to the acuity of the patients and the intensity of the service provided to them. So inpatient revenue is 20% above budget. Outpatient was 14% below, largely driven by that low number of ER visits, almost 40% below budget. And then the outpatient surgeries and other areas that were closed down for the better part of that week. So again, our net patient revenue percentage, so of the 18 million, we believe the collections will represent 3.6 million. That's almost 20% net patient revenue rate. That's extremely high for the hospital here. Again, it's because we had really good cash collection months. It requires me to dip the reserves slightly because we're collecting at a higher rate than we had estimated in prior months. Other revenue this month, we did take in about $200,000 in terms of net revenue impact from the CARES Act capability, and our essential access was about $120,000 better than budget. So our net revenues were $610,000 better than budget for the month, short month. And again, our costs were about 1.3 higher, the big piece being the $430,000 for salaries, again, $140,000 higher than budget for contract labor. You see 359 is less than the 408 from prior month in terms of contract labor, and the month before was 476. So it's on the right gradient. It's not where we need it to be by any stretch yet. So those are the big expense outliers for the hospital and for the month, but we did suffer with that in mind, especially with the closure of all outpatient services in the month of February, $660,000 operating loss against a budget that was supposed to make a small margin. So for the year to date, at a $1.2 million negative margin, and that compares unfavorably to budget by virtually 1.2 million. It's better than we did last year at this time, but still, we're salvaged to some degree on the net revenue portion by the CARES Act dollars that we drew down this month of about $200,000. So that's the year to date, and month of February. If you guys have questions, I'm going to bring Christine to my spot so that she can cover what's been really good 2 or 3, 4 months of revenue cycle performance for the hospital.
Wear my mask so I don't mumble, right? Good evening, everyone. On the first slide is our cash to net revenue, and I know Bruce has already mentioned our trends in cash as well as revenue. You can see that we've just been 10 consecutive months doing very well, some months even better than others. We hit that record back in December at 5.3 million, still achieved our goal, our stretch goal in January, and hit a new record in February at $5.8 million. So wow. And we just want to keep this up going forward. And February, I believe, had only 19 banking days. So that was a tough stretch there, but we did it. We're on a roll. So that's 10 consecutive months at meeting our stretch goal. And we'll be doing some tweaking to the reserves, because we know when you see that trend, that means that the reserves need to be relooked at and readjusted so that we have realistic goals here. So it'll be tougher in the future. The next slide is unbilled. And again, this is a very good report here. As you can see, we came in just under our goal. Our stretch goal is 5 days. We came in at 4.99. So we did that, and we're hoping to even break that again this month. Very good there. And again, that's a teamwork for a lot of people, even our physicians. everyone across the organization that makes that happen. The next slide is our new denials. Not a happy one. We're up. The industry is up. I verified that with Parallon as well as HCA. And all the journals that I read show that a lot of the administrative as well as the clinical denials are on the rise. And we have the number one area continues to be authorizations, and we have a number of teams that are working to bring that down. And the number two, of course, is medical necessity. And some of those are statuses. We have a lot of great things going on there. We have 2 new physician advisors who are helping us, such as with our peer-to-peer reviews, and we're already showing progress there. So I think that we're going to see that number, despite the industry trend, come back down towards our goal. And the last slide is our accounts receivable greater than 90 days. This is just insurance receivables. It doesn't include self-pay. Our goal or stretch goal is to be under 25%, and we came in at 24.6%. So we made that goal this month too. I do not have the professional billing slide. I will make sure that gets in next month. I do have the numbers for you. The cash was 119,000. Revenue was way down because we were closed that 1 week for snow and ice. So the revenue was under 600,000, which is way down. Our denial rate for the month was still under 1%, which is very good. And we're working with various teams across the organization to make sure that we keep that goal tight. Are there any questions?
I don't have any at this time. Thank you.
Thank you for that report. So I think what we'll need to do is, Bruce, had you completed everything for your February financial statements?
I have, Mr. Chairman, yes.
Okay, well, I'm going to move that we adopt the February financial statements. If I can get a second.
Second.
All in favor, vote by the sign of aye. Aye.
Aye.
All opposed, nay. Ayes have it. February financials are adopted by the committee. Now we will, and we thank Ms. Crawley for the revenue cycle report. We'll move over to contracts and ask Ms. Groves if she'd come and introduce these that we need to take action on.
Thank you, Reverend Stevenson. So as you will see on the agenda, I have 5 contracts to present to the Finance Committee. So I'll just start in the order that they're listed. The first 2 are with the same vendor, but for 2 different services. The first is Space Labs, and it is for our cath lab. It is bedside monitors and transport monitors. It is an annual cost of $59,703.97. Would you like for me to go through all of them, or do you want to take one at a time? Because I do need an approval for each one.
One at a time.
Yeah, you can just, we don't have to approve them all, but you can give us the information on all of them. And I think we'll come back and talk through the ones we need to.
One is again with Space Labs. It is for our PACU area, and again, it is for bedside monitors as well. That one has an annual cost of $125,188.82. The next 2 are for community health marketing. This is a consulting firm that is going to provide, for the first one, community and public relations services for the hospital. The annual cost of that contract is $240,000. The next contract for them is to provide government relations services, and that one is $120,000 a year. And then finally is a renewing contract for Presidio. They provide support for our VMware Horizon It's a IT application or IT service contract. That annual cost is $110,995.44. So those are the 5 contracts I am presenting today, and I am happy to answer any questions.
I have questions about a few that I think will be easy to handle, so I'll start with those. For the 2 Space Lab contracts, are these renewals of contracts that we have had previously, or are these brand new contracts that we're entering with a new company we haven't dealt with before?
So it is not with a new company. We have existing contracts with Space Labs, but these 2 particular contracts are for new services.
And were we getting these services previously?
Yes, we have had a long relationship with Space Labs.
Okay, sorry, my question was, were we getting these services previously from a different vendor?
No, I don't believe so. I think, if I'm not mistaken, this is new services that we have been in need of, that we are entering into contracts for.
Gotcha. And then a similar question for number 5 for the VMware. Is this a renewal of a contract that we've had previously? That's what it looks like it is. I just want to confirm.
Correct. This one is a renewal of an existing contract. And again, this particular vendor is a vendor we've had a long history with as well.
Okay. Mr. Chair, I don't have any other questions about contracts 1, 2, and 5. I don't know if you do, but we may want to vote on those 3 and then talk about numbers 3 and 4. That's just my suggestion. I defer to your wisdom.
Okay, I move to adopt contracts 1, 2, and 5, Space Labs, and Presido. If I can get a second.
Second.
All in favor, vote by the sign of aye. Aye.
Aye.
Any nays? Ayes have it. All right, so those contracts are approved. And now we're in discussion on contracts 3 and 4. And Ms. Fisher, I know the last time we were going to discuss these, but we were running out of time. And I know you had some questions. And I know you had even suggested that you had suggested maybe even having the discussion with the full board. So is that still your pleasure, or do you want to, you've got some questions you want to lift up now?
I'm happy to ask some questions now. My recommendation would be that we put these 2 contracts to the entire board for a vote, because I think they're a little bit unique and less routine than the typical service contracts we have. I defer to you as the chair if you'd prefer that we come to the larger board with a recommendation for the board to adopt or reject. I'm happy to defer to your wisdom there, but I do want to make sure whatever happens that the full board has an opportunity to look at these and ask any questions they may have as well.
Okay, yeah, absolutely. I'm okay with that. We can take this before the full board, but I do think the finance committee should have a recommendation. And typically, we've allowed the administration to bring to us those contracts and of services and items that they think are important for the hospital. And it has been our customary action to look at that, and if it's appropriate to approve. And so I hope we would, keep that in consideration, and then allow them, if there are some concerns, allow the administration to share with us. I guess the thing about these 2 contracts in particular that's frustrating is that this isn't the first time we've had, kind of this weirdness around this. And I looked at them, I read them very intensely, read through both of them. I know the expectations that's required in them, and I know the need. And so So I'm okay with us going before the full board for discussion if we can have a recommendation from the finance committee.
Sounds good. Well, I'll just kind of state my concerns, and I'm happy to have whatever parties and the, who work for National General and our executive team, whoever is most appropriate to address those, I'm happy to let them speak. I came on the board in, what was it, 2018. And so my understanding of a lot of our contracts at that time for community relations and government relations were really a cleanup effort after Mayor Megan Barry had announced the closing of the hospital. And so I felt like we were doing a lot of appropriate triaging. So my concern with these two contracts, my big umbrella concern is to make sure that we're not continuing a contract for services that were very important and essential and worth the cost during a very unique and discrete period of time in the hospital's history. So that's my biggest concern, and I'm happy to have whoever is appropriate to address that.
Well, let me address the government relations, because that's different than the marketing contract, community relations contract. The government relations is an ongoing initiative that any organization, most organizations will have that resource that they have access to. For instance, a similar hospital in Memphis would have a full-time government relations individual on staff. Erlanger has a full-time government relations person on staff. Hospitals are largely policy-driven at the local, state, and federal level. We saw an acute outbreak here with a mayor who attempted to shut down inpatient operations in a hospital. I mean, that's somewhat of an anomaly. You don't find that every day. And so sure, we needed to engage some external resources to help us to get through and to navigate some of those, because it was largely politically driven. But you also have just your general policies, policy makers that you want people to have relationships with. The CEO cannot track and monitor all of those activities. That's not necessarily something that comes under marketing. It's government relations is seen in an environment where it serves the needs and gives provides knowledge and information on upcoming or developing policies or policies that are being discontinued that might impact the hospital's reimbursement or any of those other things that you might. And again, I say at the state, local, and as well as the federal level. So it's much more pervasive than just a single incident. Now, as far as the marketing contract, this is the third vendor that we will have had this contract with since I've been here. When I came, there was a vendor. We changed a couple of years back to another vendor, which we did there was a joint venture with this vendor. And now this is the sole vendor to provide that service here locally. So if Sherry's on board this setting, then she can speak to the continuation of that particular contract, which would be the second one. I'm just speaking to the government relations right now.
Yes.
Okay.
As Dr. Webb mentioned, this is actually a renewing contract. We have had a contract with Community Health Marketing to do the community relations and PR support for the hospital for a number of years, actually for 3 years, since November of 2018. So this is a renewal. The cost is actually less than the prior contract. And the work is still important. Just as Dr. Webb mentioned, that there is a need for, most other hospitals, many other hospitals have a full-time government relations person. Many other hospitals also have a full-time community relations person on staff to help with just that, managing community stakeholders, building relationships on behalf of the hospital with community stakeholders, running events, all of that stuff. We run a very lean ship here at the hospital and do not have the resources to do all that stuff in-house.
So for the government relations contract, are we hiring community health marketing to be a registered lobbyist for Nashville General Hospital at the state level and any other capacity where registration is required?
Now, I would have to address that as a separate issue. Registered lobbyists, that's not going to be the dominant resource that we would be utilizing this for. We have a registered lobbyist as well, a firm that we've been utilizing to some degree over a period of time. So
who's our registered lobbyist, Dr. Webb?
Frazier, Megan Frazier, the firm that she works with.
Okay.
So yeah, I would expect that there would be some work in that area done by this particular entity. And if that requires registration, I'm sure that that will all be executed properly. We won't do anything that's against the law. But the main portions of that I'm interested in has more to do with the day-to-day policy activities, not necessarily trying to divert or do anything to change policies, but to make sure that we're fully informed with anything that's coming down the pike in the way of governmental activities, or whether it's, as I said, local, state, or federal. If there are relationships that need to be built with key individuals that are policymakers that might create a more favorable position for us, yes, very interested in that. That's normal. I would expect that this will be much more, again, comprehensive than what we've done in the past in government relations.
So if Megan Fraser is the real, spokesperson and voice of the Nashville General Hospital at the state level, is this government relations contract really intended to communicate with Metro Nashville, or what?
No.
What?
She's strictly a lobbyist. They have limited amount of time that they work with us. That's not a very extensive contract. It's just one of those that's been in place for a while, and it's something that we'll need to look at anyway as we go forward. So I don't want to focus necessarily on that as a substitute or in any way replace government relations, because government relations is really more of a full-time role for a hospital such as this. As you would make any comparison to any other hospital that's a public hospital, you will find that. I've not worked in a hospital that didn't have that full-time, not just a single source lobbyist.
Absolutely. So for $120,000 a year, have we thought about making this an internal position? I'm thinking here, especially in Tennessee, we could get someone who were their only client and they work full-time for Nashville General and probably cost less than the cost of this contract, where we're just one of, I assume, many clients for this entity.
I think the best value is the one that I'm doing. In my experience as a CEO, I believe that this is the best option for us.
Have we discussed having someone internal, or are there reasons why it doesn't make sense for us to have a full-time person who does this, like the hospitals in Chattanooga and Memphis?
I think the opportunity to utilize a resource that I'm using that brings that knowledge to the table. Why would I go out and bring in someone who would not have the vast knowledge of the individual that I'm going to use if I make that comparison? So I'm actually basing the selection on the experience and the time in this environment and working at different levels. So it's actually the value that comes to the table more so than just looking at an alternative of whether it's outsourced or in-house. That's always a strategic decision to outsource or in-house. We've had it in-house. Mark did a portion of that along with his legal counsel work. But what this does is it gives me the opportunity now to make a decision regarding how we're going to continue to move forward and expand the scope of that service of government relations. We're not going to replace the in-house legal resource.
All right. Thank you, Dr. Webb. And I know there are reasons for decisions being made. That's why I'm asking for them. I don't know if I don't ask, and I've been tasked in my role as a board member to ask these questions to make sure that we're doing what's best for the hospital. So that if I don't ask, I don't know.
Well, I'm happy to.
And then for the community and public health relations, again, I think the time that I came on the board, I was really looking at these high dollar external contracts for community relationships as sort of an acute need. So can you explain to me a little more, because this looks like a pretty big price tag to me for an external company, why this is necessary and what the deliverables are that we will see and that we've seen so far for this price?
Absolutely. Sorry, I'm gonna have to pull up some files, but what we have seen is years of support from community health marketing. Sorry, I'm looking for the information that we sent to you previously. Okay, so examples of community health marketing's deliverables just in the past year. So this is well beyond the challenge of, this all predates me. So I was not with the hospital during the closure situation with prior mayor or administration. So these things happened recently, and this is the support that community health marketing has brought. Media relations, they have cultivated great relationships with the local media to make it easier for us to successfully pitch positive news stories. Public relations, among other things. Community health marketing has done press releases for us. They help us with amplifying multiple news and information and expansion of services, both locally, nationally, and regionally. Government relations, so a little bit of relationship building. Community health marketing obviously has relationships. Members of their staff have relationships with constituents all over the city and state. So they have assisted us in building those relationships and helping to share the positive things that are happening at the hospital, but also helping city council members and others to understand about how legislation, et cetera, that's going on in the city, in and around the city, might either positively or negatively impact the hospital. Digital marketing and social media. There's a community health marketing distributes a monthly newsletter about Nashville General Hospital to hundreds of statewide stakeholders. And I mentioned event management and also community relations. The community health marketing came up with the town hall, the annual town hall that Nashville General does. And we have been doing that. I think this year was the 3rd year that we did it. And we obviously had to do it virtually this year. They helped to produce that wonderful event that has had over 3,000 views from all over the place, right? So we would not be able to do that with just our internal resources. So again, having nothing to do with the initial hire, they have continued to add value to the hospital and have expanded the reach and the efficacy of the marketing department here at Nashville General. And though all of those things that I mentioned would continue. So the contract includes deliverables or expectations that all of the things that I mentioned, except the government relations is separate. Media relations, PR, digital marketing, social media, event management, community relations, all those things continue to be expectations for community health marketing going forward.
Sherry,
Yes, sir.
could you, perhaps there would be some benefit in expressing that this role was actually also filled by previous firms, so it's not a new role.
Sure. So prior to, so I mentioned that this contract is a continuation or renewal of an existing contract. So we have had a relationship with Community Health Marketing for 3 years. And prior to Community Health Marketing, this community relations was handled by D.V. Siegenthaler at an expense that is actually higher than the proposed contract. So in their contract in 2018 was $250,000. So, and I would argue that our need for support and our marketing activities, just based on the capacity and capabilities of the team here at Nashville General, was significantly smaller than our needs and our capacity and scope right now, and the impact that marketing has brought to the hospital in recent months.
Do we have,
Thank you, Sherry. Go ahead. I'm sorry, Ms. Fisher. Go ahead. I apologize.
I'm sorry, Pastor Stevenson, do we have any data that they can point to? And again, this may be a question to pose and then have some information presented at our next meeting for the full board, but do we have any data to show, and I know this is hard in these contexts, but I don't think I'm the first to ask this, and I think it's an important question, to show some correlation between our money spent and efforts undertaken with an increase in patient volume, you know, an increase in Metro employees coming and obtaining services from Nashville General Hospital. Do we have any of that data to help show the value out of these contracts?
So I would argue, I mean, certainly it's not going to be one-to-one, but as Bruce has shared, our CFO has shared, not just today, but obviously over the past year even, you know, our revenues are growing. So, you know, last year, Nashville General generated patient revenues and collections just under 39 million. You know, we're projecting, you know, to end this fiscal year, well, we had the bump with the weather, but a few before the weather bump, you know, we were projecting to end the year at 46 million. You know, we are increasing our revenues, and it does not happen without spending money to actually amplify our voice and build our awareness. Again, I'm certainly not purporting that marketing and these community relation efforts are the only reason, but it is certainly a big reason why more people know about the hospital, more in our clinic services. We launched all new whole freestanding clinic, and we had to tell that story, and we had to go out into the community, and we had to change perceptions. And that's what community relations and marketing does. We had to tell people and explain to people the benefit of this whole new suite of services and lines of services. And we can't build it and expect that people will come, but we have built it and we have amplified our voice and we have told our story, and we are seeing returns, positive returns of higher revenues. So can I, put dollar to dollar? That is a challenging request. I don't know that I can, Ms. Fisher, but I can say that directionally, we are going in the right direction, and that every organization worth its weight in salt spends money to make money, right? Nike spends money, McDonald's spends money. I mean, you have to tell your story. And this is how we're telling our story. This is the organization, the company that is helping us to tell our story.
Okay. The, you know, and one of the things is I just want to make sure we're giving the administration, fair support and confidence to kind of make those decisions. I feel a little weird when we start digging into reviewing certain outcomes, unless we're going to do it aggressively across the board, because we just approved the bedside monitor contract, but we didn't ask for any return on how that will operate. And so I want the executive team to know that we've got confidence, and I appreciate the questioning, and I want everybody to feel comfortable moving forward. But we have approved millions, and I mean millions of dollars in contracts, and this is the only ones that have gotten some negative attention and has not been spoken of, I think, in the right way in some circles. And so that's a little frustrating, but I think the right course of action with your request, Ms. Fisher, would be to take it before the full board. And I'll need some help from our attorney in terms of if we approve to move this forward to the full board, is this something that we could vote on today with the board, or is that something that under the Finance Committee report, or is that something that we would have to put on the agenda for another time?
Chair Stevenson, in my opinion, in order for there to be adequate notice, it would need to come from your body to the board, and then they would have to have it noticed on their agenda with adequate notice that they were going to be taking up the matter. So it would require a subsequent agenda notice and meeting, whether that's at the next regular monthly meeting. It would be determined by who sets that agenda.
Okay.
But it could come from this committee, with or without recommendation. If you're not able to reach a determination today with certainty as to whether it's with or without a recommendation, or I mean, if you do reach that, then then that would determine whether it could proceed or not. But yeah, there will be another agenda if it moves forward from this committee.
Thank you so much. All right, so we won't take it up today at the full committee meeting. And Alex, are you okay with us moving forward with a recommendation to the full committee?
I'm fine with you making that motion. I will probably abstain from the vote. I feel as though I don't have enough information to make a recommendation at this time. And just in response to your prior statement, which I certainly agree with and appreciate, that we have an executive team to do their full-time job, and we want to support them. And this is, and maybe it's just because of my background of previously being a registered lobbyist, that this is the only, other than a few questions here or there, this is the first contract that's really caught my eye as being worthy of of additional questions and additional board review. I just want to make sure we're being a good steward of the hospital's resources and taking time when appropriate to look at things and make sure, hey, is this the best use of our resources? Are we getting a good return on it? Is this what we need to be doing now just because we did it before? And the answers to all those questions may be yes. But I just like to make sure we give it appropriate diligence. One suggestion I made previously was for our contractors to have an opportunity to answer some of those questions about the outcomes and return on investment. I don't know if that's a possibility to have at the next meeting for the full board, but that may be a useful way to address mine and any other board members' questions to just give us some confidence that we're making wise choices on behalf of the hospital.
Yeah, and there's some history, Ms. Fisher, that's frustrating me, that has nothing to do with your questions or comments today. So please don't take that as a casting aspersion in that sense. I appreciate your questioning to get understanding, and I think it's providing clarity for probably lots of others. So I do appreciate that. Now, again, I'll need our attorney to kind of tell us which way to go here, because we have just two persons that are present on the committee, so we don't have a motion with just one person.
That's a little different question than what I was anticipating as far as how to get the motion for a vote. I was going to answer the question of if she abstained from voting, depending upon the number of votes cast, the majority of votes present and voting would govern whether the motion passes. Give me just a moment, Chair Stevenson, and I'll see if I can determine and give you advice about how to proceed with a motion. But I think Ms. Fisher may simply be abstaining from the vote, but yet participating in the motion process.
Okay,
I want to speak for her.
that would still only be one vote out of two.
Right, but a vote would then, if she's present but not voting, so one vote present would be the majority. It's the way the vote would be determined is that the number present and voting. So if the motion would carry with one vote.
Pastor Stevenson, what if we do a different motion than our normal one, which is, move to place this matter before the entire board for their consideration at the next meeting? I don't know if that's an appropriate way to do it, but then at least we're moving it out of the committee to the full board for consideration.
My advice there would be that the motion could be made to advance it out of committee to the full board without a recommendation or a non-recommendation for board consideration. And then that matter could be voted on by these committee members.
Okay, yeah, that's fine. I'll make that motion to, I move that we advance this to the full board for consideration.
I second.
All in favor, vote by the sound of aye. Aye.
Aye.
All opposed? Ayes have it. All right, good. I think they're waiting for us in another meeting, so I'll entertain a motion to adjourn.
Motion to adjourn.
Second. All in favor, vote by the sound of aye. Aye.
Aye.
All opposed? Ayes have it. Thank you so much to everyone for your information presented today. And we'll see you at the other meeting here in just a second.
Thanks, Pastor Stevenson.
All right.